Our guest today is Professor Johan Smitz, MD, PhD, based at the Follicle Biology Laboratory at the Medical Faculty of the Free University of Brussels in Belgium. He graduated as a physician first, but then subspecialized in reproductive medicine and received his PhD in 1993. From 1986 onwards, he has been the head of the endocrine laboratory of the University Hospital. He became professor of endocrine physiology and reproductive medicine in 1997 at VUB and founded the Follicle Biology Research Laboratory at that university. Currently, Johan is an emeritus professor and co-founder of several companies, startups, aiming at commercialization of in vitro maturation. Johan, thank you very much for accepting my invitation to this interview.
Thank you, Dimitri. It's really a great honor for me to be online with you. Thank you for the introduction. I think you said it already all. I just want to emphasize I have a conflict of interest in the sense that I'm still emeritus professor, but also involved into companies that will deal with commercialization in the future of the topic that I'm speaking about today. This is just for completeness. So thank you for having me here.
Can you tell us a little bit about how you came into the field of reproductive medicine and specifically became interested in vitro maturation?
That's, of course, a long story that I will try to tell you in a very short way. I had the opportunity to do my specialty in clinical pathology in the University of Brussels that had decided to invest in the early 80s in reproductive medicine. And so I did my specialty there, and Professors Van Stertegem and De Vroey, that you might know, invited me to continue and join their group. So in the 90s, I was really fascinated by the work of Gosden and David Baird in UK, who pointed to the possibilities for ovarian tissue freezing. And nothing of that was done in Belgium at the time. So being in a reproductive lab and having the opportunity to have culture rooms, etc., I decided to have more interest into that. And we founded a lab called the Follicle Biology Lab, because it's nice to freeze tissue, but we all know that after that you have to do something. So with that tissue, either transplant it or culture it in order to have large oocytes. So this was the initial thought and the project, and we went to workshops that were organized in UK by Gosden and Baird. But then I think that a second point that struck me at that time very much is that in animals, everything of assisted reproduction is entirely directed starting from in vitro maturation of oocytes. So it's not done in the same way as we do it, like stimulation and then getting the oocytes. No, they go into the ovaries, into the immature follicles, but also starting from slaughterhouse material. So that was a second point that started to interest me. And then, of course, it is impossible for me to have large animals because I work in a clinic and there are not enough fields around the clinic. So we decided to work on, like many people do, on rodents. And so there we had excellent examples of research on rodents. I'm thinking on John Epic's lab in Bar Harbor. And so having also mice that we could culture in our place, we started to set up ovarian tissue culture starting from primary follicles in the mouse or primordial follicles. And so that was in fact the start. We built a good culture lab that was capable of studying ovarian function in vitro. That was the beginning of everything. And that was in the end of the 90s. And so finally, having all these activities there with a group of students that came in, it culminated in companies asking me to contribute in maturation projects for on the human tissue, human ovarian tissue. And that was very possible because we had, in the meantime, we had a big IVF clinic, and also ICSI had been said. So there were many patients in our clinic, and this brought along the possibility also to have our hands on human tissues for research. That's in short the history.
If you can give us some major milestones in the history of in vitro maturation.
If we start like at the end of the 90s, like between 95 and 2000, I think it was striking that when you read the papers in Biology of Reproduction and other journals, in vitro maturation in animal species had become almost a routine technology for livestock breeding. And IVM in human had already at that point some clinical interest. We all know the interesting work in Montreal and in McGill from Tan and Chian. Also, some groups in Europe, especially Scandinavian groups, had started to look into IVM in human, the group in Finland and also the group in Denmark. However, there were few groups there, and they had only, there was a small interest in clinics, and I think the clinics were still struggling with a lot of optimization issues of how to stimulate the woman and how to optimize embryo culture for normal IVF. So this deviation of doing IVM rather than the classical IVF was at that point, there was not much interest at that point for IVM. The results, like for any new technique, were lower than for IVF. And so I think the end interest was low to continue that. But however, some things happened in basic research, and from work on small animals like the rodents, or in large animals. And for example, the way or the understanding of the physiology of the follicle at that time. And one of the things that struck me or hit me very much was the work from, for example, Marco Conti and Aaron Shui in US, in Stanford, I think that they were, or they are still. And they worked on the PD3 inhibitors in the oocyte, showing that you could arrest the maturation of the oocyte. And so it was clear that from the work in bovine, and I'm thinking here especially on the work in Czechoslovakia or in Czechia at the time, Fulka and company, that had shown that IVM can be better if you first do, if you arrest the nuclear maturation and you, in order to get the cytoplasmic maturation happening. So there are two types of maturation that have to happen. The nuclear means that the maturation, initially your oocytes are not capable of undergoing germinal vesicle breakdown, but when the follicle becomes larger and larger, this is something that is acquired when they become larger antral. Yeah. So if you are working with very small follicles, like in the human 2 to 6 millimeter follicles, few of them have not yet the capacity to undergo this nuclear maturation. So they stay blocked by themselves, even if you take them out of the follicle. But those that are a bit larger, after 6 millimeter, you take them out and they will go in spontaneous maturation. And this is an inappropriate moment because the cytoplasm of that oocyte is not fully in a condition where the nuclear maturation that ends up in normal chromosomes on spindles cannot be accomplished with fidelity. So what you need to have is this nuclear maturation and cytoplasmic maturation happening in synchrony. But if the nuclear maturation is already starting, I mean, you are in a milieu that is not good for the quality of the embryo. So the idea of arresting the nuclear maturation came from the animal work. You find that back in publications. But the question is, how are you going to do that in a proper way? And you could do it pharmacologically. And there, Marco Conti showed that it is possible with PDE3 inhibitors that are very specific to the oocyte. So it's a nice way to do it. But then, when we tried that out in the early 2000 publication of Noguera in my lab, we saw that despite the fact that you can block the nuclear maturation, the cytoplasmic maturation was not happening. And we found out later that the reason for that was because the connections between the nucleus and the oocyte and the cumulus cells was interrupted. And we know from the fundamental work of John Eppich that it is the cumulus cells around the oocyte that orchestrate the cytoplasmic maturation in the oocyte. So you need these cumulus cells, and if you take them out in vitro, you arrest the nuclear maturation not with any product, but around the same time. So we tried first the pharmacological molecules, which would be a very long way to implement in the clinic because we would have to show safety, etc., etc. What we did is we found, I mean, there was the work from a Chinese student, Meia Zhang. He's working now in China. He was working in John Eppich's lab in Bar Harbor, and he found that there was a natural molecule, which is C-natriuretic peptide. And so C-natriuretic peptide is the natural arrestor in the follicle. So it is high in a follicle. And by being high, it keeps the maturation, the nuclear maturation, blocked until the moment that the cytoplasmic maturation is okay. So what we said is, well, it worked. We first started to test it in the mouse, and we found that it worked very nicely, very nicely. We could block for 3, 4, 5 days the mouse maturation. And with my students in the lab, Sergio Romero and Flor Sanchez, who published most of this work in the mouse and in the early human papers, we said, well, there is nothing really that works well in our hands in vitro maturation in the human clinic. Why would we not test this CNP that works so nicely in the mouse? So we jumped immediately with this natural product in a human model, and to our surprise, it worked very nicely. And the big thing was that if we compare the oocyte cumulus complexes of the two, so PDE3 inhibitor or CNP, we saw that with CNP you can keep the connections between cumulus and oocytes, while with the PDE3 inhibitor there were no connections anymore. It was like an empty space. We looked with confocal microscopy, etc. So this was really the beginning. And then it is nice, you can show, you can block, you can keep the cumulus connected. But then the next question is, how do you then design your medium to make these cumulus cells happy around the oocyte? Because we were using whatever medium was usable for human, but then you have to make optimization to culture these complexes. We were using IVF media, and they are not really made for this type of culture. You have much more cells, so it needed a whole adaptation, and this took us like 6 months to a year to fine-tune this before we were testing it first on donors, because I wanted to make blastocysts first with this system. And in Belgium it is possible because you can make embryos for research after getting the permission of a federal commission that you have to explain why you are doing this. So this was actually the beginning of what we call capacitation in vitro maturation. And we say capacitation because, yeah, like sperm, before it can fertilize, it has capacitation to undergo. And we said, yeah, I mean, the term is nice. We will do this. We will give it the same name for the oocyte.
What, in your opinion, then, the role of the follicular phase?
Not need a follicular phase. I mean, because you all know that the growth of the follicle in woman's ovary are quite similar to the bovine, with waves, with 2 or 3 waves. It has been very well demonstrated by the work of the people in Canada, the group of Pearson and Beerwald. You know these papers, very interesting papers. So the point is that you have to choose one of the waves before that that there is any selection in the ovary ongoing. That's why we might come to that also, is that I'm always talking in the papers and the clinical groups that joined this initiative with me, the Vietnamese, etc. If you see, we always mention between 2 and 8 millimeter, because it is considered that at 9 millimeter, it's already a selected or a dominant follicle, and then you have all the bad things that could come from this large follicle, from this dominant follicle, that we actually don't really know well. From that work, it shows that once you have dominance, there is a lot of inhibition happening to the smaller ones. And so it is, if you want to have many oocyte cumulus complexes, it's illogic to let dominance happen, because by letting dominance happen, you kill all the potential rest. The whole thing is that it might sound a crazy idea, because now we are doing IVF and we are always used to push to 17 to 20 millimeter follicles under a huge influence of FSH, that's we know. But actually, this route that we are promoting here is to take the eggs with the cumulus cells, the oocytes surrounded by cumulus cells, at the moment that there has not been any counterproductive action on them. And then, of course, the question for you, or the difficulty in your hands, is now you have to set the conditions to get these eggs in the right maturation stage. And of course, at 6 millimeter, I take that as like a medium diameter, at 6 millimeter, there is not all the receptor systems and the molecular systems are not yet present to be triggered by factors that you would give in your culture system. And as an example, I take LH is not a good example, because you know that if you take an oocyte cumulus complex, there are no LH receptors on these cumulus cells, or a very low, maybe extremely low concentration. Maybe they can become expressed in your culture. But take the EGF receptor. The EGF receptor is not functional in cumulus cells when it is in a small follicle. But if you first put that in a culture system that you keep, where you keep everything quiet, and you at the right physiological concentrations of, for example, insulin, estradiol, etc., you can push these receptor systems to get expressed quite quickly. And only then you come with the triggers that will induce nuclear maturation. You see the system? So, of course, you can say, yeah, but between 6 millimeter and 17, normally you have at least 8 days of growth of a follicle in the body of the woman. So we are replacing those 8 days by a 2-day in vitro system to get the whole thing in the right conditions to be able to mature, fertilize, and give live births. And that's the reality where we are today, that apparently with even 1 day of what we call a capacitation culture, where we arrest the oocyte, followed by 24 hours of, 32 hours of maturation, you can get normal blastocysts, still at almost the same rate than you have from large follicles. So what is the gain? You could say, yeah, Johan, you have a complex system in the lab. That's true. It is maybe a bit more complex, although we can discuss what that complexity means. But on the other hand, if you see that for the patient, it would mean that she can come at any day of her cycle. You just put your ultrasound on the ovary, you see the picture, you think, yes, I can puncture these small follicles. And then you have to do 1 day of culture work more. Yeah, I think that outweighs the whole thing. For the patient, it becomes extremely simple. Her ovary is unstimulated, etc. We can go in the details later. What are all the positive things and the negative things? But at the end, I think it can be very positive for the patient, and that's, I think, why we should develop it. I think IVF works nicely, but just think on the possibilities that the woman could have. No stimulated ovary means also she goes home the same day and she doesn't have pain in the belly, etc. And all her embryos can. We have now a system that we can discuss later also, where we can do fresh cycle transfer here. But actually, today we freeze everything and we transfer when it is appropriate for the woman. So that's extremely making it simple for the woman, maybe a bit more complicated for the gynecologist who has to do a pickup. He has to learn it, and a bit more work maybe in the lab. But that's evolution, I think.
My question was more of a scientific question,
Okay.
trying to understand what would be the role. Why does nature create this extended follicular phase
Ah,
when an egg is apparently ready for
well, I
development
think,
maturely?
well, Dimitri, you have always many, many follicles at the beginning of your cycle. Yeah, you have like how many? 15 in a young woman or 20?
Right.
Nature, the evolution is if you let them all go, it's impossible for the woman. She cannot have quintuplets, etc. So there is the pressure of suppressing what is pushed to explode there. Okay, this suppression phase needs the whole endocrine system. You have to kill everything around the queen follicle, the dominatrix follicle, and then your endometrium needs to be prepared. And we know, and we know badly from our experiments, that it's not so easy in IVM to have an endometrium in phase. We have a couple of publications from Brussels showing that we cannot get in phase. Now, I think we maybe did not put enough estrogens in it, etc. So there is a moment that needs to be sufficiently long to get this endometrium right. And yeah, nature, I mean, you have, I think, two elements. If you to summarize, you have the killing of all the cohort of follicles that come out to one or two, maximally, and then you need to have a sufficient long number of estradiol exposure that comes from that dominatrix follicle to the endometrium to let the embryo implant. It's a very interesting question that you poses there, and the same is true actually for the entire folliculogenesis. Huh? So we speak here. I hope everybody will understand that here in this audience is that we start only from to talk about 2 mm follicles, but when you go back to the primordial follicle, you have work that has been done in Edinburgh. You know that in the group there from Bert. I mean, Bert unfortunately passed away, but I mean the experiments that were done there show that from early secondary human follicles you can have very quickly antral follicles, almost in a few days. And while in normal life, it takes months. It takes 2 months and a half. Yeah. So why is it possible in 2 weeks? I was also surprised of that. And when I discussed it there, they say, yeah, but I mean, if you put it in vitro, it's a completely other story. And you can, by what you put in vitro, you can push certain receptor systems. And so in a cell, things can change quite quickly. Okay, although, I mean, the egg, if it needs to grow, I think it's like a volume increase of 400 times in human. It's very big. And so I would think that it needs a slow pace. And then, okay, the same principle, I think, at the end of folliculogenesis could be the same reason why, why is it so long in vivo while you can do the things in vitro so quickly? It surprised me also in the beginning, but I cannot find a better explanation than that, you know. You will say, yeah, a human is not a mouse, it's true, but it is something that we can really easily study in mouse. We can once have a discussion about that, because in mouse you can isolate a lot of follicles, for example, with 2 layers of granulosa cells in the beginning. So from early pre-antral follicles, you culture hundreds of them and you put them under different conditions. And what you can do is you can stop your culture after day 6 when they are very early antral, 7, 8, 9, 10, etc. And then you look what is the competence to undergo germinal vesicle breakdown, reach metaphase 2, fertilize, and make blastocysts. And we have I have some paper that we published in Fertile Sterile very long time ago. Mouse, maybe it might not have interested many people, but anyway, it was just for the concept of what you say. From what moment do you have competence for embryonic, good normal embryogenesis? But also at the other end, you know, how far can you go? Because once a follicle starts to grow and you give the impulse, so you isolate it, you put it in culture, you give it a bit of FSH, and it needs some FSH, it goes, and then in vitro, you have to stop it at some point. And there you can do it after 7, 8, 9, 10, 11, 12 days. And then you see that there is a maximum and then it goes down. So you have over maturation, which is another thing.
Oh,
And
yes.
my question, how much of over maturation is happening when we stimulate and we stop the LH trigger? Some doctors say, oh, I can go and stimulate 2 days longer. Is that really good for the egg? I'm not sure. And then the same question is what your question is before the maximum. You know? How can you be before that maximum of maturation? You have to integrate that concept in the fact that you have a heterogeneous cohort, always in women, I mean, mostly, except in young women before 32 maybe, but otherwise you deal with different diameters. And then you have to shoot once to once, and that then you have automatically some more mature and some less mature. A lot that we can learn. Unfortunately, with in the human, it's very difficult with patients that you want to treat. But in Belgium, we can have models. At some point, yeah, people might decide, yeah, but you are just, I mean, is it still, I mean, you can use donors, egg donors, and study all these things very carefully and very well. But yeah, you have to think on the ethics around it. And I would love that some other countries also have the same liberty. Um, I think our technology is hugely getting now popular, I would say. Well, hugely popular is a big word, maybe. It's well accepted in Asia, while in Asia doing the research might maybe not be so easily acceptable. You see, it has nothing to see with the clinical application. The clinical application there happens, because we validated the safety of the method, and so it's now shown because the children are there, they are growing normally, etc. And they are psychomotorically completely not different from ICSI and also not from normal children. We have the publications on that. But what you say, finding out the mechanisms in human, interesting, but it will be very hard to achieve. It will cost some money, but not impossible.
From the point of view of practical embryology, what are the additional steps in the lab which are happening, if you can describe it for us?
Oocytes or cumulus cells are retrieved in a way that they are not naked. So this is the first thing that you as an embryologist will have to set with the clinic. The clinic, the doctor will learn how to aspirate and drill out. It's a special movement drilling of the follicle. But then also the negative pressure, so the needle diameter, etc., is important. You have a needle of 19 gauge that we use.
Very small.
Very small. That's important for the pickup. And then you do a pressure of minus 120 millimeter mercury. The tubing is not too long, not to cool off, because these things are apparently more fragile than the normal eggs that come out of a large follicle. I mean, yeah, that's what we learned out of the practice. So you have a couple of little technical things, but they don't cost you anything. You just have to know them and to put a good pump in your lab and to order a finer needle. I mean, that will not be really the cost. What the embryologist has to learn then is he gets a more bloody follicle fluid. There is not much follicle fluid because the follicles are so small, but out of the mass of, I would say, mix of tissue and all this, you have to find these oocyte cumulus complexes. And that's a question of training of 1 or 2 days with somebody who is used to do it, in order to get as many as possible, preferably all. And it goes over a filter. So there are different methods to do it. We have tried to standardize it now in a way that you should normally get for a PCOS patient, like between at least 15 to maximum sometimes 50 cumulus complexes. And that means that you will have to deal with 50 oocyte cumulus complexes in a very systematic way. So the comments that we get is, oh, yeah, but that's so much material that we have to handle. And so sometimes one person who is normally dealing with 10 or 15 oocytes, suddenly he has to deal with 30. This needs a little adaptation in how you organize your lab. There is no machine that you need that is special. We just recommend certain pipette diameters. Why? Because we culture the oocyte with the cumulus cells. This is something that is relatively fragile. If your needle is too small, you can understand that you will strip off the cumulus cells from the oocyte, and then you don't have the positive effect of the cumulus cells happening. So you see, that are the little things that you will have to do. But the media that we would like to provide comes together with a working procedure and a training on beforehand. And I think this is not something novel. I mean, it has been used for vitrification. So all new techniques that are implemented, it's not to you that I have to explain that, need a bit of training. And what is a bit? A bit is 2-3 days that you go to a workshop where people are doing that. And you come into your lab, and then you start with those cases that are easy, where the doctor sees a lot of follicles, a lot of small follicles, no dominance. Maybe he will not retrieve, he will retrieve only 50% of the eggs out of these ovaries in the beginning. But he will slowly build up his competence, and after 20 cases, he will be as good as Dr. Lam in Vietnam to do it. So these are the changes. And for the rest, you need an incubator because we see that capacitation IVM needs to happen under ambient oxygen. So it is not low oxygen incubator. We have done a comparative study. It's clear that the 20% oxygen is, or the 17, 18% is needed for that step, probably because you have so much of cumulus around. But yeah, like with any new method, I think we have something that is robust enough to go into the clinics. But of course, like IVF, I think that you guys will do optimization. Each of you will have ideas and say, oh, well, I will do it slightly different. So I see the start should be relatively rigid until the moment that you get the same results as those that are published. And then the method can only improve, I think.
And how soon after this the eggs will begin to mature? And how synchronous are the processes?
It's a very important question, especially when you do ICSI. We see that we tested initially some culture durations, like, so you have first the 24 hours or 22 to, there is a flexibility for the capacitation incubation. So the first incubation, you have there some flexibility, which is nice for you in the lab so that you don't have to work after hours. You see, if the
Mm-hmm.
ICSI falls in a bad time, nobody's happy. Everybody gets nervous. So this first incubation, there is a bit of flexibility, a
Mm-hmm.
couple of hours. So what we did is, um, we say between 20 and 24 hours. But you know that this is for the 2 to 8 millimeter follicles. Imagine we go into smaller follicles in the future, it might be a longer capacitation. And we can do it for 48 hours. We have tested that already, but our procedure at this moment is made for 24 hours for the 2 to 8 millimeters. So after the 24 hours or 20 to 24 hours, you wash, like you say. You have to do that with the pipettes of right bore, etc., so that you don't get the cumulus off the oocytes because they still play a role also in the IVM phase. So
Mm-hmm.
they come then into the IVM medium, which is not with gonadotrophins, but with EGF-like factors.
Mm-hmm.
And then you get exactly, we tested 28 hours, 30 hours, 32 hours. And we saw that after 30 hours, the number of eggs that still mature are really minimal. That's what we have tested in a lab where they have a huge amount of material, like it was in Vietnam. So we see that it's, if you do 30 hours, you will have 70, or I would say 60 to 75% of the material that is metaphase 2.
Mm-hmm.
And you will inject that immediately.
Mm-hmm. Mm-hmm. And I guess for exact protocol, we will refer to your publication.
Yeah, but we will provide. So our idea now is we are preparing a kit per patient, and we provide that with training and with yeah, with the procedure, of course. It comes like a normal product from commercial.
Mm-hmm. Okay.
Um, but yeah, we are very very I would say motivated to help the labs that will start to do that, to do it right, so that we have immediately good results. That's our motivation. It's not just sending a kit to a lab and saying, yeah, you just play with it. No, 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 no. Please do it first according to our recommendations, and then you move into, I mean, if you want to, everybody has ideas of research, then that's nice to move on, to improve the system, because yeah, there is still improvement to do, like for IVF, still there are improvements possible. But it opens new possibilities for sure, like you say.
And what is the main indication at this time for applying IVM?
Well, if you want me to say it very simple, I would say all patients with an anti-Mullerian hormone more than 5, go into an IVM system. The higher the anti-Mullerian hormone, the better will be the results of IVM compared to IVF. So those results with very high AMHs in IVF are in our hands not so good here. I mean, I'm speaking about our own labs here. But if you do in those patients IVM, it's good. And those with a very high AMH also, the risk of having complications with IVF are big, you know. So IVM is a very good solution there. I think, so that's, I would say, PCOS patients or a high AMH patients, not the full-blown PCOS, but also those with a lot of follicles and a good count. So young patients, why not starting to do something without a stimulation and trying it out with the ovary that you have there? In some places now, they start not only to do pickups in the follicular phase, they are testing the luteal phase to show, but that's in patients that are, of course, if they have a luteal phase, they are not PCOS, but people start immediately to experiment and to see, yeah, is it true that we can also do pickups now in the luteal phase? And I can say, yes, it works, but our standard protocol now is we are not validating it on luteal phase pickups. We have just validated, I think, if you ask me, in PCOS patients with a high AMH, with an AMH more than 5. Then in the cancer field, I think we have a publication from the Russian group showing that when you do this on eggs that you can get after dissection, these are eggs normally that come from the medulla region, from small follicles. If they have cumulus and you put them in our kappa medium, they have more blastocysts than when you put it in a traditional IVM medium, showing that, yeah, this capacitation is really doing something. But we have no babies from that because actually the eggs are frozen, as you know, or the embryos that are made from these eggs are frozen for later, for when the patients are recovering. But it's the best what they have. Then in patients, I think it has been validated in patients with receptor, with FSH, NLH, well, FSH receptor mutations or deficiencies, those that are normally stimulated and they have a good AMH, but you see there are a lot of follicles, but they don't grow. Okay, when you do IVM on them, it works very nicely. So this is for FSH receptor. Why? Because we don't really trigger this receptor to have a maturation result. We use the EGF receptor to push the whole thing.
Feel that maybe your way to induce resumption of meiosis with growth factors receptors rather than regular LH receptors, maybe improving meiotic division.
Yeah, I think that's a good summary of what is the difference. Yeah, absolutely. I agree with you. I mean, it was, I mean, it is not, I mean, if you see the work again of the group in I think it's Stanford with Conti and Zama, where they look to the EGF, the importance of the EGF family in the follicle, it's obvious that the best eggs came out of the follicles with the highest amphiregulin. So it's amphiregulin that we choose as the key factor to work with, you know. Then there are a lot of questions, should we add other factors? But we had at some point to be very pragmatic and to say, yeah, everything that you add in a medium, you will have to validate it. And I mean, you know, validation is the whole thing. You might have results and be happy with what you see in your patients, but then you have all the regulatory work that comes after that. First of all, you need to have your material sourced very carefully. Who is going to produce it? You have to show that it is stable. You know, there is a whole work that comes besides the nice biological work that we all are happy to do. And of course, we try to do that very professionally now in order to get something in the market that of which we can be sure that it is stable and safe and everything, and that it gets approval. I mean, we will go for normal approval like for any product that comes into the market. Huh?
You're removing medication from the equation. You're removing stimulation from the equation.
Yes.
So in some ways, you are trivializing this whole process.
Yes, but I think this is absolutely true what you say. And yeah, this is inevitable. I think is inevitable that there will be some pressure against. But on the other hand, I'm quite liberal in my mind, and I think that finally it is the patient who has to choose. Huh? You can. I'm not saying that we should change everything into IVM. I'm saying let the patient choose. If the patient is really happy with the actual treatment, she might rather choose that. But I can imagine that there are many categories like those young. I'm thinking on the young woman who want to avoid any hormones. Those young women who have couples where there is a male factor, why should the woman be treated? Maybe she has to choose something really. I mean, the pickup we cannot avoid. You need the eggs out, so the pickup is there. But we can hugely improve the way we do the pickups also. It's true that, yeah, it becomes something very simple. Probably with a device, you can very easily retrieve those follicles when they are at a certain diameter. I'm just thinking it's only the beginning of something that will maybe take again 10 years to be on a very high speed and accepted by everyone. But what I'm saying is, if we start today to implement it in our best cases or those that are least complicated, and I'm saying least complicated means young with a lot of follicles, etc. They don't need any stimulation. So why not putting them in an IVM system that is probably much cheaper for them and for society? I mean, whoever pays for that, it will be a cheaper business. Yeah, that there will be people not happy about this. It has been in many fields of medicine like that. Huh? If you go from removing extrauterine pregnancy by doing Tommy, and then suddenly there come the laparoscopists that do it much simpler, etc. Every new thing has resistance. IVF had resistance also. But I think we have to see what it brings to the patient and let the patient choose finally. Um, but there will be also some new things to develop, and I can be open here. For example, are we sure that every day the cohort that is there is the best to pick up today? Or do you believe that by doing an ultrasound and a good analysis of the follicles, you might be saying, not today, we wait for the next cohort because the ultrasound picture globally is not favorable? Maybe because there is I'm not just imagining, there is a follicle that has already reached some domination in the ovary, or that you have an old corpus luteum that is. So you see, now we look to the ovary in the way of being practical for IVF, but this might completely change, and that's why I think that we have to go and talk to people or develop projects with people that look to the ovary in a different way as we have ever looked at it.
Okay.
And like also Marc-André Sirard that works on bovine, he says that we don't know anything about the predominant phases of the ovary. We have to rediscover a lot of things. And people might say, yeah, but we did work 20 years ago. Yeah, but all our tools have changed. And I think we are just at the level where we show that something works and we have 1,000 children, so it gives everybody some comfort, but it is again material for publications for the next 10 years. Huh? And PhD students can have in the clinic as well as in the lab a lot of positive things to gain from such a technology.
Certainly. Now, let me ask you this. Have you had any cases where patient with not very high AMH successful with in vitro maturation after failure with regular IVF?
Yes, there are some reports emerging now, but I must say that we have encouraged the people to start, like I say, with good normal responders, just to have the things in their fingers. Now we will start studies like with our major group in Vietnam. We will go down in AMH also, you see. We will not only take cases of good AMH, we are going to take cases that are that have a lower AMH to see is there somewhere a lower level. I think AMH is a very interesting marker for us for IVM because it's very difficult to define what is a certain patient. But AMH is one figure that englobes a lot of characteristics of the patient. We know it is related to some hyperandrogenism. It is also related to some very good things in oocytes at certain moments. So let's use those new parameters, and I think the role of ultrasound will be also major to make a good selection.
What do you see as the main obstacle at this time for broader adaptation of IVM?
If the doctor need to be open to learn to do a pickup in small follicles. I think with the ultrasound machines of today that have become so perfect with 3D and everything that you can imagine, where you see the Doppler and a fine needle, I think we have really to redefine the needle there. It works with the current needles, but I think we can have something better because imagine you have a good needle, an easy needle for these small follicles that is atraumatic but with a sharp tip. I mean, we can list all the things that is needed. Somebody needs to develop that. If a normal person in any place can do the pickup very easily, and you have the oocyte cumulus complexes in a lab, you expose them to the kappa media, you could eventually freeze at that point the tissue, you see, and or the complexes, and elaborate it somewhere else. So it opens a lot of things. If you start to think about it, it's really a whole menu that we can go through. So, but the obstacle is the pickup is a first obstacle because I say that by experience. When I'm in a meeting, we do a workshop. I ask the question at the end. Now you have seen the pickup. I asked to the doctors, what are you going to start now in your own lab? Oh, well, I'm still a bit fearing these small follicles and the vessels, etc. I think you need to overcome this fear. Of course, you need to work still controlled. I'm not saying that we should become cowboys. No, we have the tools to do it in a very simple way. And I think the work of Lan has shown. She has now in the clinic teach 10 other doctors routinely, and they have no complications. That's important to have no complications, no infections, no hyperstimulation, no bleeding, because this unstimulated ovary has a completely different consistency. Yeah, it is harder. It moves, so we have to think on how to handle that part also. You can do a short total anesthesia rather than doing only a local anesthesia. But these are all tunable things. Then another barrier is that for the moment, if we come and we present this method in a lab, they will say, oh, but that's so much work to find these follicles back, or these oocytes back in the dish. But then I say, yeah, but if you train yourself like is happening now in Vietnam, and you arrange the work, the way you arrange your search, instead of having one person looking at it, you put a second person, you can go 2 times as fast. And that's important for the quality of the complexes. So it changes a bit the things in the lab, and you know that every change is a good reason to be resistant to that change. Otherwise, yeah, the people would say, yeah, it's a day longer of culture. Yeah, but I mean, a day longer of culture, the plates sit in an incubator. I mean, what does it mean more? No, nothing. So you see, it are more subjective things that are there, because purely medically speaking, there are not many disadvantages here. Eh? There are not more complications. Yeah, it's all practical what we are talking about here.
What advice you would give somebody starting IVM?
It doesn't need to be a huge lab, etc. I think I take the example of the Ho Chi Minh lab, Miduk, who is really is now the leader, I think, worldwide, together with the Japanese labs of Morimoto in Osaka, etc. I mean, at least in Ho Chi Minh, it's not a huge lab, but this lab is organized in a very efficient way. They work very quickly. And I think when you have these cells coming out of the body of the patient who is laying in the next room, I mean, the pickup takes probably a bit longer than a normal egg pickup, because the doctor, she wants to go for the last little follicle that she sees, because every follicle contains some material. Not to say that all this material is necessarily usable or giving finally a good oocytes. There is some selection that needs to be done in the embryology lab. Yeah, like if the egg is naked or when it comes with fluffy cumulus cells around, you know that it's not from a healthy follicle. Okay, but then all these manipulations, like you have a pickup that takes you maximum 20 minutes, this is kept at right temperature, right gas, right pH, right everything. It comes into the embryology lab and it's treated very rapidly under controlled atmosphere, and then it comes in a capacitation medium. So the time between pickup and capacitation medium is a key time, and we would say, okay, do everything to try that this is done within an hour. I think this is safe. So what does it mean? It means that the doctor needs to have a training and the embryologist. And the doctor and the embryologist should go in couple to a place where they are doing it. That's how we are actually teaching some labs now. This training is offered in Vietnam, and soon we will have other places to do that also in US. We need to have a training place in South America. I think every continent will have one major lab that trains other people. But that's something very simple. You have to register and get your training. I would say to begin, because you asked me an advice, begin with what is validated in the literature is PCOS with a good AMH, more than 5. Start with that. Of course, I know the pressure, and that's maybe the mistake that in the past has been made with IVM, is that despite the fact that there were not appropriate media and that IVM was like a panoply of things that happened, I think here now the whole thing is more standardized, and the doctors are pressing to have their IVF failures in this system. But if you do that from the beginning, everybody get discouraged. If you start from a normal PCOS patient, the first cycle, she should have 40% live birth. That's what the data show here. Yeah, with one blastocyst. You should have, I say 40, maximum 40 at this moment, which is good, from this technique. From follicles smaller than 8 millimeter. Come on, this is really a big thing. We have just our paper that came out in Fertile Sterile today in the February issue, comparing unstimulated or stimulated PCOS, yeah? So no FSH at all or FSH with FSH. And we see that in the no FSH group, the live birth rate, and it is 60 patients in this group, live birth rate with one blastocyst transferred is 38.1% live birth.
And how many blastocyst patient gets, on average, per retrieval from those 40 follicles?
Yeah, it is not, I mean, it is not 40, all 40. You have to see the average is somewhere around 20, if I'm right, follicles. But you can, it is between 1 and 3 good quality blastocysts. If we compare that to IVF, it is still lower than IVF. So the maturation rate is 65% on average. Yeah, you have that have 80, you have others that have 50. But generally, it is more than 50. Average 65% in both groups. Because you asked me lately a question, is it true that IVM from non-stimulated has higher success rate than after a short stimulation? In the study that is published today in Fertile Sterile, you see that the maturation rate in the two groups are exactly the same. But what is different is that we had one blastocyst more without any FSH, which I would have thought it would be
Yes.
opposite.
Yes.
Without FSH is one blastocyst more. So try to understand that. I'm happy that you will help me thinking why this could be.
Okay.
So in that group, we have live birth of 38% live birth.
Is it statistically different
No,
with
because it's
one
only
FSH?
no, because it is only it is 60 patients in every group.
Okay,
And
so it
it
okay.
is 6.5% difference.
I see.
So 6.5% out of the 38.3. So the plus FSH had a live birth rate of 31.7. But with the difference of 6%, you cannot reach that with a 60
Yeah.
patient. Yeah.
Right.
But
So,
I would have expected the reverse. That's what.
but there's no significance. You cannot say anything. So, without now.
I agree. I agree. I agree.
Well,
So
mhm.
to say it very short for you, because you asked me the question. So from follicles 2 to 8 millimeter, maturation rates are between 60 and 75%. And you can then make the deductions yourself. Fertilization by ICSI is similar
Okay.
than IVF. Blastocyst over 2PN is 30%.
Okay. That's pretty respectable.
Is respectable. I know in a control group that is equal. I mean, I want to control it with patients that are hyper responders. So those with a good AMH also in a normal IVF group, because otherwise you compare apples and pears. I know that in that group, the blastocyst is 40%. So let's say that I would like very much that we work so that the 30% comes also 40%. But I'm almost certain that we can easily reach that. Why? Because today, when you do the pickup from the small follicles, it is sure that we cannot retrieve out the eggs out of all the follicles. So if you become more competent with your needle, every egg more that you get will be reflected in the blastocyst rate. It could well be that we leave eggs there of a good competence.
Yes, I can see your point. But it does seem very respectable rate of blastulation. Particularly, we're talking about patients who did not receive any FSH
Yeah,
at all.
yeah,
So it was um, pure IVM without
Pure
anything.
nature. It's pure nature. Also,
Don't say nature. No, nature. No, 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 no. It's not nature. But, but, but this I would not agree. But uh, without any FSH, which
yeah,
would be given to them, without any follicular phase of any length. Uh, so this would be quite remarkable. I'm very impressed with your work. Uh, Johan, it was a pleasure speaking with you. I find your work fascinating, very important. I think that it will continue delivering more indications as we move along. Johan, thank you so much for your time.
thanks, Dimitri, for inviting me. I think it's important that these type of interviews, I realize their importance because, of course, you might write many papers, but often the papers don't get read or misinterpreted. So I think it's a really good tool to communicate to the fellows in US and to my colleagues in US. And I thank you for making this possible, and also for your always good questions and discussions about concepts. Because after all, we have to also try to improve our thinking, because the technology is advancing so fastly that it creates so many new possibilities, and we have to use them fully also in our field, which is a fantastic field actually, infertility treatment. Thank you
Yes.
for your, I would say, generosity with your time also.
For now, thank you very much. Bye bye.
Thank you. Bye. Bye to the colleagues. Bye.